So we have a 71-year-old, let's see, okay, trying to hide the top of my, oh well, we have a 71-year-old male, has a history of HFrEF, presents to the emergency room with acute altered mental status. He's confused, though he follows commands. Collateral reports that he has been declining over the past few days and eating less. There was no reported head trauma. Exam significant for the patient being alert and oriented times 1 to 2, baselines times 4, with no noted focal neurologic deficits. The patient's unable to spell the word world backwards and is tangential during conversation. He's had no recent med changes. His meds are lisinopril, Coreg, spironolactone, and Lasix. Initial CBC, BMP, including calcium and chest X-ray, are all unrevealing. UA has trace Luke esterase with 1 white blood cell reported, no RBCs. So what would our first step be? Would we empirically start antibiotics for UTI? Obtain a head CT scan to urgently rule out central cause? Begin an EEG? Perform medicine reconciliation with collateral? Or start scheduled melatonin QHS to normalize the sleep-wake cycle? Dun, 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 dun. So, although that UA, I shouldn't speak with sarcasm, the UA is not super convincing of any UTI and he's not endorsing symptoms. An EEG, at this point, an EEG is something I turn to later in a delirium workup. A scheduled melatonin is typically not indicated to normalize sleep-wake cycle. We use a lot of other methods first. Adding on a medicine is not a typical geriatric thing to do, even though melatonin is one of the more benign ones. And then the head CT to urgently rule out central cause, he has a non-focal exam, no deficits, and a few other lack of risk factors, I would say, that he would not need a CT. So I'd actually begin with the medicine reconciliation and other items with collateral. Make sure we didn't miss anything besides the meds we see there. So how do we assess for delirium? We use something called the confusion assessment method, or CAM, which is here. And we're looking for this 2 first components: acute onset or fluctuating course, which he had, inattention, which was reported, and then either disorganized thinking or altered level of consciousness. Disorganized thinking is typically when people are unable to answer our alert and oriented questions, and then altered level of consciousness is when people are either really agitated and fighting with us, that's when we notice it most commonly, or when they're falling asleep during conversation. So he satisfied the diagnostic criteria for delirium, so we know he's delirious. And why is that important? Delirium's not normal. We have to ask ourselves why it's happening. There's increased risk of death, cognitive decline, length of stay being increased, and even institutionalization after the hospital stay. Plus, delirium can last months and lead to cognitive decline afterwards. So it is a big deal. Do we get head CTs in everyone that comes in? Well, let's look at the data. In a 2015 study, 220 hospitalized patients underwent CT scans for delirium. And out of those, only 6 were actually like positive head CTs. And within the 6 positive, 3 were on anticoagulation. So out of this, 3 out of 220 like positives for undifferentiated delirium basically means that without potential risk factors or anticoagulation, it was very rare to find something on head CT. In the another 2015 Vijay Krishna study, 400 patients that had CTs, 36 were noted to have delirium. So this is a bit different of a retrospective study. And they were looking for acute intracranial changes on those CT scans in the noted to be delirious patients, only noted in 4 patients, all of whom had preclinical clinical symptoms and signs to warrant imaging. So that's things like focal neurologic deficits, for example. So in people who don't have symptoms ahead of time or additional reasons to actually get a CT scan, there's a very low rate of misdiagnosis, around 1 to 2%. So it's suggestive of not getting a head CT for all comers. So use head CTs with clinical suspicion. You think about risks. Has there been head trauma? For a subdural, anticoagulation increasing a risk of subdural, focal deficits on exam, or things like metastases as well. And in like terms that I think of with expert opinion, if the course is atypical, or if there's a decompensation you weren't expecting, then you could also consider getting a CT at that time. So It's not indicated for everyone. So it was not indicated in this case. We consider with focal deficits, a fall with head trauma, which he didn't have, or a systemic deficit or neurologic deficit. And consider when there's an atypical course of delirium. So if there's a change in consciousness, a concern for emboli or metastases, or, this is someone we don't know the history. Maybe this has been in a course that's atypical, but they haven't been able to tell us that. So we have to get additional information that we're not getting through history and physical. And that's all I've got.